Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care. Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had the privilege of sitting down with Enrique Balaguer, who is the Chief Growth Officer for MedZed, which is one of the largest ECM, or Enhanced Care Management, and community supports providers here in California, but started all the way back in 2014 as a direct care provider. In today's episode, Enrique talks about the journey of MedZed over the past 12 years and what they do in other states beyond California. We talk about the outcomes that ECM provides, a success story, and some of the challenges that come up with the work that they do, and ultimately, what's ahead. We hope you enjoyed today's episode. Feel free to check out other episodes of Pop Health Podcast by visiting us at pophealthpodcast.com, checking us out on our YouTube channel, or visiting us wherever you listen to your shows. Thanks, everybody. Enrique, thanks so much for joining the show today.
Glad to be here. It's a pleasure. Good to be with you.
Yeah, definitely. So I had the privilege of meeting Enrique, meeting you, back in October of 2025 at a California Association of Health Plans conference at a dinner. And folks, what I liked about Enrique is he is a soccer fan. So, or football, I don't know, however you want to say it. So we connected pretty quickly, and we realized both our organization, or my day job, I guess you can say, did a lot of similarities. So that's how we connected. And Enrique, before we get into the work that we do, that you do there at MedZed, we'd like to have our audience get to know you a little bit, maybe outside the workplace, so you can tell us perhaps a fun fact, a hobby, something like that about you.
We talked about soccer at the dinner. My lifelong passion has always been cars and car racing. So since I was a little kid, so I'm an amateur car racer.
Awesome.
In my spare time, my 22-year-old son and I race old BMWs all around. I live in Massachusetts, so we do the circuit, the club racing circuit, all around New England, New York. We go down to Virginia sometimes. So yeah, a lot of fun.
Wow, that sounds. When I hear race car driving, I think like danger. Have you guys ever experienced a moment of danger?
Have I crashed the car in all the years? Yeah, I've done it, but being inside a race car is a surprisingly relaxing place to be. Everybody's going in the same direction. Yeah, you're competing. Yeah, you're going fast, but you're wearing all of this safety gear, and it's very zen. It's one of the things that you do that really, really, really clears your mind, because when you're doing it, you can't be thinking about anything else. So it's a space and time where you have no job, you have no mortgage, you have no family, it's great. It's a great discipline.
Wow, that is cool. I just got Apple TV. I know like F1. I know what you do is different than F1, but yeah. I know racing is, even though you don't see it like as much as like football or NBA in the headlines, racing is actually a big deal, and there's a lot of people. It's a big deal.
Yeah. Sports car racing now around the world. I mean, it is a big deal.
Yeah, that is cool, man. I would not have expected. I assumed you were going to talk about soccer or something along that, but different sport. So that is awesome. So before we get into MedZed, I just want to hear a little bit about how your career journey ultimately ended up at MedZed.
Yeah, I am. So I always say my formal training is in public policy. So I'm a policy analyst by training. Very sort of numbers driven. But I've always been an entrepreneur by inclination, and more specifically a social entrepreneur. So early on in my career, to me one of the coolest things has always been to be able to use business principles to address some social need. So I started early on. I for 8 years I ran a nonprofit technology company that really sort of drove me into healthcare.
Okay.
Aimed at helping low income working people figure out how to get access to public benefit programs like SNAP, like earned income tax credits, all of the things that they needed to actually be able to stay at work and not have to rely on TANF. So for me, that combination of being able to take business principles and tackle a social need, and then actually get paid for doing that as a way of demonstrating the value that you're providing has always been a bit of a holy grail.
Yeah.
So my career has taken different turns, but when I joined MedZed in 2021, for me that was a return to that basic core concept that in our world at MedZed, we get paid essentially when we help people get better. It doesn't happen if we don't do that. So while we are a for-profit company, there's a really important mission component that's baked into the core of the business.
So you ended up at MedZed in 2021, and when I think of MedZed, I think of things like enhanced care management, which we'll get to in just a second, community supports, but you guys were doing things before the California Advancing and Innovating Medi-Cal Initiative, and you guys are also a national or multi-state entity. Before we get into kind of the breadth of what MedZed does, I know I've asked you this, but I'm sure our audience wants to know, MedZed, like, where did that name come from?
Yeah, it's funny. We joke about that it sounds almost like a pharmaceutical product in some cases, but no. So the MedZed, the founders MedZed was founded in 2014. So Scott Schnell, Neil Solomon were essentially childhood friends, all the way back to first grade. Neil's a doctor, Scott's an entrepreneur, and the idea was the initial MedZed started out life as a medical practice with the idea of being able to bring primary medical care to wherever people were through a hybrid model that combined field teams of nurses on the ground beaming in doctors and nurse practitioners via a telemedicine platform. So MedZed, basically, they said, well, the medicine modernized, and it became the first and the very last syllables, med, for medicine, and modernized. So that's how MedZed came to be. Like a lot of, if you ask people about how their company brands came to me, you get all kinds of interesting stories.
Awesome, man. Yeah, thanks for sharing that story. I've met Dr. Solomon a few times when he's been at different events that I've been at. So that's pretty cool. I didn't realize he was one of the original guys or co-founders, if you will.
Yeah, he's a co-founder.
That's awesome. Cool. So you mentioned you joined in 2021. So at the time, we're going to probably focus most of today's episode on California. So at the time in 2021, this was before the CalAIM initiative officially kicked off. MedZed was already doing a bunch of work in California, which helped propel MedZed into the CalAIM initiative. Are you able to share briefly about what was happening in California at the time? And then eventually we'll talk about multi-states as well. But can you start with that?
Yeah. So, so the listeners of this podcast, know this well. The precursor to CalAIM was the whole health homes, and then the whole person care initiatives. So two discrete but related programs. We were an early participant by virtue of the fact that Neil is a California guy, and we had some good health plan connections in California. We started providing health homes and whole person, supporting health homes and whole person programs across the state, and so for us that made it. The transition to ECM, while I think was a big transition for everybody, for the state, for the health plans, for the providers like us, we were already in a good spot in that some of the really important kernels of being able to run a successful ECM program we already had those in place. So we had the managed care plan relationships. We had a pretty good understanding of what was going on around state policy. And we had and most importantly, we had the know-how, the prior, call it prior art of already having teams on the ground and having not all, but most, because ECM was significantly different, but most of the technology and the infrastructure to be able to support a program. So we had a head start, which has really helped us with our ECM efforts.
Yeah, that is awesome. I've been in the, I guess, California healthcare industry for a long time, but not in Medi-Cal until the Cali Medition, and I was like, who is this MedZed company? You guys were throughout the state, many counties. Tell us, you guys are not just ECM. So could you remind the audience or tell the audience what ECM is? Some of our listeners may not know. Most will. And then two, you guys do more than just that in California.
We do. We're also a community. We're also a community supports provider in a limited sphere, and I can talk about that in a minute. Enhanced care management as part of the 1115 demonstration waiver in California really, and it's interesting because California was really forward thinking in recognizing and then implementing social supports. Some people call them, social drivers of health. Others will call them health-related social needs. But the notion that tackling people's health-related, I'll use health-related social needs sort of as my preferred terms. My preferred term is a direct contributor to clinical health, or sometimes unmet health-related social needs will be a direct barrier to people having good clinical outcomes or access to clinical health. So the ECM essentially has made addressing health-related social needs a benefit. It's a Medi-Cal benefit. If you are on Medicaid or on Medi-Cal in California and you meet the criteria for one of the populations of focus that were established for enhanced care management, then it's a benefit. It's a part of your Medi-Cal benefits package. It's a little like health homes in California and other states, but California really is the only state in the country that has made this part of your benefits. So you can get access to care coordination. You can get access to have someone help you with your transportation needs to get you to your primary care appointments. All of those things are things that you, as a Medi-Cal member, you're entitled to. We do on the community support side, which are not part of they live under a different waiver, but they're not part of the Medi-Cal benefits package. But in our view, just as important, we do what's called a housing trio. So we're helping people with housing transition. So people transitioning from being homeless or at risk of homelessness to housing. We work on tenancy sustainability, which means once you're housed, we sort of help make sure that you can keep your housing. And then we do housing supports. So that triad, which really has to travel together, is part of our portfolio, and it marries really well with the work that we're doing on the ECM side. Yeah, so it's interesting that over the past year, the community supports, our housing trio has been the fastest growing service line. We've got right now. We've got about. We've held about 2,700 people.
Wow.
And one of the interesting things is we've actually been pretty successful at getting people transitioned into permanent housing. It's in the hundreds, which doesn't seem like a big number, but if you start thinking about the California housing market, it's growing, and it's a really important part of the work that we're doing.
Yeah. And I know you guys as a whole, serve many, many thousands of folks in different services, each and every year.
We have about 7,000 people on panel right now in California, sort of across our various service areas with and growing. I mean, one of the things that we're grappling with right now is getting a little better at forecasting referral flows.
Yeah.
From the health plans. We're also making a significant investment in a community impact partnership program that is really aimed at, and it's kind of like what we're doing with 24-hour home care with you guys, as a way of really developing other referral channels that are more rooted in the community. It's good for the organizations we partner with. It's good for the members, and it's good for the state as well. It's a kind of a win-win all around, in that because a lot of these folks who are showing up at community-based organizations, or it could be at the YMCA. It could be, there are many places. It could be at medical providers.
Absolutely.
That turn out to be ECM eligible or might qualify for community supports, are people that have self-identified in many ways, and don't need to be found. They don't need the same level of persuasion than someone who comes in on, who we sort of know may qualify, but have to go and start educating and reaching out to. So it's a good model.
Yeah, you bring up a good point. The state does want providers to connect, right? And I know at one point DHES was talking to the health plans about, hey, we want community-driven referrals, and that's through relationships, not just the health plan identifying members and giving them to the ECM. Yeah. So glad you guys are doing that. Before we get into what you guys do outside of California, I'd really like to know, on the ECM side, and maybe community supports too, what are the outcomes that MedZed is really driving towards with these folks on enhanced care management? What are we trying to get them to, and how do you kind of report back to the state that you've been successful?
So let's go with the outcomes. The overall aim of the program writ large really is intended to give folks who have become disengaged from primary care as a grounding principle, for any number of reasons. Many of them are actually, they're social reasons. The people that we work with tend to have really complicated lives, that may include substance use disorders, that it may include behavioral health issues. But the overarching goal, that's the one that we drive to, and it's the one that the state is driving to, is really to reconnect folks to primary care, to behavioral care, to behavioral health care, to specialty care in non-hospital settings. So it's really to avoid at the end of the line here, what we're all collectively trying to do is to keep people from using hospital-based services as the primary point of entry into healthcare. It's expensive. We all know it's expensive. If that's your point of entry, typically you're getting there when you're at a moment of crisis, and so a lot of the preventive measures or mitigating things that could have been done, it's too late for that. Now you're in a place where you have to deal with more complicated issues. By the way, that's what we do around the country. So it's not just it's a very similar aim. So yes. for us, within the construct of ECM, getting people to their PCP is that, to us, that's because we do that outside of California as well, is one of the most fundamental things that you can do. If you can reestablish somebody's primary care in a way that is sticky, that's durable,
yeah,
you've achieved one of the. It's not the end outcome, but it's sort of the key precursor to all of the important stuff that can happen downstream of that.
Got it. So once let's say you have a member on your ECM panel, an active member. You've been able, your team, your lead care managers are my understanding is the name of the role that most of your staff are on that are helping manage, X number of members per lead care manager. Once you get them reconnected to primary care, they're engaged in their care. Is the goal ultimately to have them, like from the health plan? The health plan is your client, right? Like you guys are paid by the MCOs or the health plans. Is the goal to get them reconnected to primary care, get them engaged in their care so that ultimately they no longer need as much care management because they're self-caring in a sense?
Yeah, I mean, ultimately that's the goal. And acuity varies, but this is not an inexpensive intervention. So the goal here, and again, I'm drawing on the MedZed philosophy writ large, which ties in very closely to ECM. But for us, when we think of a member who's disengaged, who's driving uncontrolled medical spend, who is potentially driving down health plan quality metrics, we want to do three things. We want to do three things for that person. One is, we talked about it a minute ago, we want to reestablish their primary care.
Yeah.
And I, again, in a broader sense, right? We want to make sure that they're reconnected to their PCP, to their behavioral health and specialty providers. We want to address the health-related social needs that present barriers to care for that person.
Yep.
And I mean, we have crazy stories about things that present barriers to care. Sometimes you're just like, we had one gentleman in San Francisco who stopped going to his primary care doc, and we reconnected with him and said, "Hey, like, what's going on?" And he said, "Look, the charger for my electric wheelchair broke, and I can't." And so this was a $49 solution, but unless you had that tight connection, you didn't. That was the barrier. It was a charger it was a battery charger. So for us, it's getting overcoming those barriers, and then the third part is giving the member the skills and the wherewithal to be more self-sufficient and better able to navigate the healthcare system on their own. And it's never complete independence. Some folks will need will need some ongoing care management from the care management teams at the health plan, but they no longer require that really intense level of support. Our goal is always to, we call it graduation, but it's the state calls it disenroll. We want to graduate people when they're in a place that they can fend for themselves better. They may still need support, but they also have some of the know-how of how to go get that support for themselves. So that's the end point.
Awesome, man. Well, I appreciate you breaking those three, main points down. You mentioned, that's not just California, but across the board. I'm happy to transition outside of California to what you guys do across the country. Before doing that, we talked about outcomes. I wanted to see if there's any other outcome you wanted to emphasize in California before we jump over to what you guys do outside the state.
So interestingly, we can track internal intermediate outcomes. So one of the things that we're really proud of is our engagement rates.
Okay.
If someone comes to us and says, "Hey, like, what do you guys do differently or better than other organizations who do this kind of work?" We would say the first thing is we're really, really good at finding and engaging people.
Yeah.
Because really nothing else can happen until you do that. So for us, we're in the 30 to 40% engagement rate, which are high engagement rates. The state has not yet released outcomes that the outcomes data that were, I think it's coming, but not released, the outcomes data that we're all looking for, which is, are we keeping people out of the hospital, and are we keeping people out of the emergency department? So we know what we do. So good engagement data. We're very good at getting people to their primary care docs. So that's for us, and so do those two things. Eager to see what the ECM program has delivered in terms of cost savings and from reduced utilization, sort of cost savings to the system as a whole. Unfortunately, it's not just we. I don't think any of the ECM providers have direct visibility into those outcomes yet.
Yeah.
It's coming, but we don't have visibility into those outcomes.
Yeah, it's the data sharing, the outcomes connected to ECM. It sounds like, why not, right? Like, why can't we have that? But it's very complex.
So the preliminary, look, everything we've heard from the state is that the program is actually meeting its goals. It's saving money.
Yeah.
We'll have to see what that looks like in dollars.
Definitely.
I mean, intuitively, you would think that that's the case, but haven't seen the numbers yet.
Yeah, I'm with you. I'm eager to see it. And anecdotally, we hear the success stories like you're talking about. We've seen some see community supports data, but yeah, that's great. I wanted the audience to be aware of the challenge of engagement really quick. So I want to provide a little comment on what you just said about the 30 to 40% engagement rate. A lot of the members that are referred to MedZed or ECMs or even some community supports, sometimes those members are identified by the plan and they're provided to MedZed. And so these members aren't necessarily saying, hey, pick me, right? They're often, complacent about their care. So it is hard to reach some of these folks who might be dealing with experiencing homelessness, right? One of the things I like about your organization, Enrique, is I know some of your lead care managers are out in the community knocking on doors, right? Because they've been assigned a member, they want to help, and maybe the phone doesn't work, right? And that's a lot of work to go door knocking when appropriate, right? So yeah, I really applaud you guys for really trying, and anybody out there who's really trying to engage with these folks, because once that trust is built with the lead care manager, that's, at least this is my perspective, and correct me if I'm wrong, when you guys build that trust, boom, those goals of overcoming the SDOH barriers, those goals of reconnecting to primary care are much more achievable.
Yeah, it is. I mean, that's where the magic happens. The people that we work with, I mean, that's what we said earlier in the conversation, the importance of these community-based organizations, of looking for community referrals where people may self-identify, or at least have already established contact with a trusted organization, helps clear a big hurdle. So if we get a health plan file with referrals, it's a harder lift. And I think the point I'm trying to make here is that many of the people who are disengaged from the healthcare system have legitimate reasons. They're real. They've had poor experiences. It's their reluctance to engage is not always unwarranted. They have good reasons. So our job, and one of the things, so again, to sort of think about what really makes these programs successful is to really persistence, being able to go and talk to them. And sometimes you don't talk directly to them. I mean, one of the coolest things I see with our navigators, our lead care managers, is that they're not just from the community, but they're of the community. So if I'm looking for Gavin and Gavin doesn't want to talk to me, turns out that maybe I went to high school with Gavin's cousin, and I know, and I can go and talk to and this is real. These are real, and talk to Gavin's cousin and say, hey, can you talk to Gavin and tell him that we're actually here to help. And there's tons of stories like that of people making those connections with the goal of establishing the trust that needs to be established to be able to then engage the member. And then you're absolutely right, what you said earlier. Once that happens, keeping that one-to-one relationship is also what really matters, right? So it's not that you have a lead care manager, it's that you have your lead care manager, and that person is your Sherpa for the next 4 or 5 or 6 months or 9 months to help you get to where you need to be.
Awesome, man. Yeah, great example there with the cousin and the familial connection there. And your care manager, you're not, calling and rotating different people on the phone or talking to a different stranger every time you call.
Trust is huge.
Yeah.
Trust is huge in this space.
Definitely. As we wrap up, I want to jump over to making sure the audience is aware of what you guys do across the country. So, Enrique, can you talk a little bit about what you guys are doing in other states as well?
We call it Complete Connect, and and Complete Connect is it looks. I mean, substantially the goals are the same as are the same as ECM. We are trying to work with people who are disengaged from their care, who are driving uncontrolled spend, and potentially having an adverse impact on health plans quality metrics. So both of those things have financial implications for the health plan. This is where it goes back to this notion of we're addressing a depending on which way you tackle it, from a financial issue by tackling a social problem. So for us, it's a little bit different than ECM, because in California we've got good state funding that supports the program, and the ROI, at least it's going to become explicit, but it's implied. In California, it's implied that there's a sound economic reason for running this program. In programs that we run around the country, we have to make the business case for how we do this. So it's not that, hey, there's a program that we can help you implement. So it's a little bit, the conversation with the managed health plans is a little bit different in that we have to say, look, you have despite all your best efforts at using your care management teams, which is great, at using your quality teams, which is great. In some cases, they have community health workers going out into the field, which is great. If you still have a sort of a hardcore population of folks who remain resistant to your outreach efforts and your engagement efforts, those are our people. Those are the people that we can help you engage, and so that's our value prop. It's as our CEO said, once the health plan one time said, you guys are like the Navy SEALs of care management, right? And in a sense, it is. I mean, we're purpose built to go after and care for that sort of really hard to manage population.
That makes a lot of sense. Well, I really appreciate you breaking down what you guys are doing in California and the other 4 states that you mentioned as well, Enrique. I've known about you guys for a really long time and have wanted MedZed on the podcast for a long time. So really appreciate you making yourself available for our audience. So I know many of them probably work with you guys, or their patients are your patients. If folks want to learn more about MedZed or get connected, is the website the best way? What would you recommend?
Yeah, I mean, go to our website. You can reach us there. We've got good contact forms. You can find me on LinkedIn, or you can find me directly. I'm always happy to talk about about what we do and figure out how we can, if they're a partnership, or just if you just need advice. I love talking about this stuff. There's passion here, so always happy to connect with folks.
Awesome, man. So passionate about MedZed, about care, Medi-Cal, Medicaid, soccer, and race car driving. Got it. Cool. Well, Enrique, great to connect with you again today. Appreciate you being on the show, and I wish you the best of the rest of the month of February.
Yeah, no, thanks. This was super fun. It was good to talk.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.